and of course there's now the police enforce against them. They're not rules that anybody want to have in place, but they're rules that need to be in place, and everybody must follow them and stay at home wherever possible, unless for those 4 reasons. We're crystal clear about that, and we've set those rules, we're enforcing against those rules, and we reiterate those rules because that is the best way to be able to bend the curve down and stop the spread of the virus. Alex Thompson from Channel 4.
Good afternoon to you both. You'll both be aware that in the last few hours, the directive has gone out to NHS ICU doctors to the effect that if hospitals are using a lot of oxygen machines, the entire oxygen supply to the hospital can fail, from CPAP, face masks, ventilators, right through to operating theatres. So what is being done to address that critical problem? More widely, we understand 3 hospitals in the past few days have come close, indeed, to running out of oxygen. What's being done to increase supplies to ensure that doesn't happen in the coming days and weeks when clearly the number of patients will increase?
Yes, this is a very important operational question. We have adequate supplies of the oxygen that's needed in hospitals. We need to, of course, make sure that each hospital has that available. We have had an equipment failure, as I think you referenced, and we therefore had to divert some ambulances. But this is the normal operation of the NHS when there are things like equipment failures. Of course, interest in it is heightened because of the nature of coronavirus. But the quantity of oxygen and supply of oxygen is something that we've been working very hard on, and we have a very high degree of confidence in the supply of oxygen. Is there anything else?
So I was just going to add actually some comments that I think Professor Steve Harris made a few days ago, which is actually the signal that this is a positive sign in most cases. If you have a whole system where it's unusual in the UK where we have a National Health Service, it means that we have a system of flagging where there are potential risks or problems before they actually become a significant problem. It is the strength of our system that we have these flags going off at regular intervals. And I think his comment back to the questions at the time was, this is a positive thing, we flag them, we deal with them as they arise. But to reinforce what the Secretary of State has said is there is no insufficiency of oxygen. And I think the public should not be concerned that if they become ill and need hospital admission, that care is available to them.
Great. Charlotte Ivers from Talk Radio.
Thank you, Mr. Hancock. You changed and updated the rules on PPE a few days ago, and I was speaking to a doctor who said before these changes he was moving between treating COVID patients and cancer patients who had compromised immune systems, and he was terrified that he would be deadly to them because he didn't feel it was adequate. So can I ask you, first, was he correct to be scared? And if he wasn't correct to be scared, why has something had to change?
Well, we've upgraded the guidance, so now in all instances it's at or above the levels of protective equipment recommended by the World Health Organization. But we've also upgraded it following more being known about the virus. As we've learned about the science of coronavirus over the last few months, so we will keep upgrading and improving guidance as we learn more about it. So that was the main reason for the changes, to make sure that we reflected the latest that we know about the virus. And I think that the new guidance set out on Thursday has been very widely welcomed and provides clarity about what protective equipment is needed in which circumstance. And then, of course, we have to deliver and make sure that that protective equipment that is needed, according to the guidance, gets to the front line. Jenny?
Yes, so I think just to support that, I don't know the individual case that you are describing, but clearly it wouldn't matter whether you were a cancer patient or a patient in another setting. We want to maintain good infection prevention and control procedures, and the bedrock of that in the UK and throughout the NHS is actually systematic practice. It's one reason why this country is very good. We don't get a lot of nosocomial infection, as in onward spread in healthcare settings, because it is the basic, which we're also obviously been teaching the public around good hand and respiratory hygiene in a systematic approach and using PPE carefully, which keeps that at bay. But I think the new guidance, what it has done is it's reinforced the fact that our guidance previously was actually inconsistent with WHO guidance. It was endorsed. It was reported back on the 27th by WHO and recognised. But what we're seeing now is slightly different prevalence of disease, and we've adapted our guidance to manage that. So there's a level of uncertainty, and there's a level of protection which is higher in some high-risk procedures. So the areas we're very concerned about from a clinical perspective are what we call aerosol-generating procedures under pressure. So this is where where you get a potential airborne spread, and we want to make sure people have absolutely adequate protection there. And then the other issue is recognising the settings in which people are working. So the most obvious one would be if we went back, say, 4 months, very unlikely anybody in the emergency department would see anybody with COVID-19. Actually now, in some of those settings where it's uncertain for professionals when they're first seeing patients and understanding them, it's important that they have cover in anticipation of what might be a different prevalence of disease. So that's basically, I can give you more detail of the actual equipment, but that's as effectively what we're trying to do. It's covering the changing circumstances.
Did you have a follow-up? You put your hand up.
Yes, I was just going to ask you, talks about us now knowing more about the disease. So knowing what we know now, should we have had these higher levels of protection from the beginning? Were people at risk?
Well, the thing is that you can only make decisions based on the information that you have at the time, and we're constantly looking for new information about this disease so that we can improve the guidance that we have and the response that we have to it. So it's the question that we have in government, and that I ask myself every day is: are we doing the right thing now, and what can we change to improve our response for the future? And so you can have a debate about the past, but you have to take decisions on the information that's available at the time. And I think the previous guidance was the best guidance possible on the information that was available at the time, and then we've upgraded it.
Yeah, so I think to support that, it's not so much, we are obviously learning all the time about the disease, but the basic guidance was entirely appropriate, and as I say, endorsed by WHO, despite, I think, some media reporting about differences. But the important thing is we are now operating in a slightly different environment, so it's the uncertainty that some clinicians, not all clinicians, find themselves in, that we have reviewed where that is to ensure that they feel safer in those environments. I think there are other opportunities we're learning from. So, for example, where we are finding that you can reuse masks safely, for example, with appropriate cleaning and technology, that's very helpful because, of course, we need to keep in mind that regardless of supplies and advice, the whole world wants personal protective equipment, and it's really important that we all use it appropriately and judiciously, exactly have it in the right places where it's needed, but not wasting it, so that the people who are working on the front line, whether it be in care homes, domiciliary care, or in the front line of an emergency department, they have the right PPE at the right time for the right clinical risk, and that's what our whole basis of the guidance is based upon.
Thanks very much. Jane Merrick at the Eye.
Thank you. How do you square what the Queen said today about the nation's attributes of self-discipline with your warning about having to toughen the restrictions if people don't stop gathering in parks? That's to the Health Secretary. And to the Deputy Chief Medical Officer, what is the testing strategy for care homes and prisons, given that these are emerging as major hotspots for cases and sadly deaths? Are prisons and care homes going to be next in line for mass testing after NHS workers?
Well, I think we're all looking forward to seeing what the Queen has to say and watching her address and listening very carefully to it. I think the message from all of those of us across the board is very clear, which is that we need perseverance in the face of some great challenges. And that also means perseverance in following the rules. And I couldn't be clearer about my emphatic requirement of people, which is backed up by law, to follow the rules that we've set out and to make sure that people stay at home. That is the number one thing that you can do. And we've set out those 4 exemptions, and people should stay at home unless they're going out for one of those 4 reasons, and those 4 reasons alone. Yeah.
Thank you. So absolutely, you've highlighted 2 very critical domains, if you like, for public health surveillance and intervention. That's been recognised right from the start of this incident, and in fact it's recognised before COVID-19. We always keep a close eye on care homes and prisons because the setting in which people live is potentially problematic. So for care homes, clearly, you tend to have a collection, in the nicest possible use of the word, of potentially elderly or more vulnerable individuals. That's one issue. And then certainly in prisons, you are intentionally, through a prison operation, holding people together. So both of those environments are very well recognised. In fact, Public Health England hosts the WHO Collaborating Centre for Healthy Prisons. So we have a lot of experience and actually advise other parts of the world. And I know that the key consultants there have been working with Ministry of Justice and with the Prime Minister on establishing and looking at how this environment should be treated. You asked specifically about testing, and testing in both prisons and care homes has always been on the priority list. So once we moved from containment to delay, if you remember the categories of testing that we have are clinical care of patients in hospitals as an absolute category, because that's how we manage the safety and the benefit of that health intervention. But what we then do is test in care homes and prisons. What we do though, is we wouldn't necessarily test everybody, because you want to test where there is going to be a positive advantage to doing the testing. I'll stop in a moment. And we usually test up to about 5 people to establish, it can vary depending on the setting, but to be sure that we've established what the issue is. It's usually quite possible in a setting like that to understand then, on a clinical basis, whether there is a case. It may not be laboratory confirmed, but it would be a presumed clinical case.
Thanks very much. Jim at the FT.
Sorry.
Oh, sorry, you wanted to come back, Dane, sorry.
To come back on the question on testing, that you said that they are next in line, but when will that testing take place, given that there are probably lots of people who are very concerned about their relatives in care homes, and also people who work in care homes and people who work in prisons? Yeah,
sorry, I perhaps didn't explain myself clearly enough. So for any care home outbreaks, whether it relates to a worker or an individual resident or a prisoner or somebody supporting him or her, those tests happen now. They are in the prioritised list already. So the groups of people who are routinely tested and have been ever since we started responding to this incident include potential outbreaks in care homes and prisons. That's been going on right from the start. In terms of other workers, so as we go forward for NHS workers and frontline care workers and responders, clearly those are in the priority group, because we recognise that those workers, we need to think of the care sector almost like the other arm. We talk a lot about the acute hospital sector, but we often forget that it's the care sector who are operating in the community nurses, domiciliary care workers, who are equally important in our drive to manage this incident. So they will come within prioritised key workers.
Does that answer the question, Jane?
I think it was just to get clarity on when that testing would take place for those workers.
Yeah.
There's no specific timing.
So the outbreaks happen already, and the other workers will be falling into the expanding programme, which has been ramping up, as you've heard, and I think has been reported on a daily basis this week.
Thanks. Jim from the FT.
Secretary of State, could you please tell us yes or no whether the government is preparing to take equity stakes on taxpayers' behalf in some of the large companies which have found themselves in major crisis because of the pandemic? And if so, do you think that Richard Branson's Virgin Atlantic is a worthy recipient of that kind of assistance, given the 2017 Virgin Care sued your beloved NHS after losing a contract, and given that Sir Richard lives as a tax exile on Necker Island. And the question for Jenny Harries, I know you might say it's too early to speculate about how the lockdown might end. Neil Ferguson seemed to suggest this morning that there could be a kind of staggered way of doing it in terms of different age groups and different regions coming out of the lockdown before others. Is that possible?
Well, I'm going to not answer the first question, and then Jenny can answer the second one. My response to the first question is this is an area in which Rishi Sunak has been doing unbelievable work. He's recognised around the world for the first-class response, economic response that we've got here in the UK, and overall the protection of workers, protection of self-employed, right across the board. They've taken the right steps, and I think done it with remarkable speed. Of course, there's enormous consequences, economic consequences, for businesses of all sectors of the decisions that we've had to take. And none of these decisions on social distancing aren't the sorts of decisions anybody would want to take. But I think the way that the Prime Minister and Chancellor have responded on the economic front has been absolutely first rate, and I'll leave it to them to answer questions about the details of what might happen, might or might not happen, which is their best place to do rather than me. Jenny, on the second point?
Yes. So I think the brief answer is all things are possible. And it's important because right from the start we've driven the response from science, and we have modelled, and Neil clearly has been one of the key contributors of that modelling group and in us understanding what interventions we need to put in at what time. And I know there's a huge amount of work ongoing at the moment looking at both the individual packets of intervention that have gone in, so we staggered them in. Some of them had significantly more impact on the way in, and those are the ones that we put in at the time to give the maximum benefit. But clearly, what we don't yet know, and I think this is critical, and I didn't hear Neil's interview this morning, I apologise, but what we don't yet know is how the disease on a whole population basis has affected our immunity, how many of us have had it and how many haven't. And that is important if we can find that information, because it will give us an understanding then, as he has obviously described, by region, for example. So London has had a lot of cases here. If it was found that a large number of people were immune, then it may be that different interventions could come off sooner or later. Equally, if we find that there are areas where there have been less cases prevalent, then we need to be very mindful what will happen if the social interaction levels increased in those particular areas and what the impact might be. As you will have heard many people say before, the very last thing we want to do is have put in all of this effort with everybody trying to do the right thing, almost everybody across the country, and then find we lift the lid too early and we have a second spike. It will waste the effort that we put in, and we still need to get over that very first hump, really, of the epidemic curve, and then look at detail. But I can assure you there is a huge amount of work involved in that, and Neil clearly is contributing to it.
Thanks, Jim. The next question from Harriet at the PA. Hi.
Hi. To the Health Secretary first, many people who have spent the last couple of days and socially distancing themselves will be wondering if it's safe for them to see family, if they've also been following the guidance over the weekend. Are they safe to do that? And if not, can you explain why not? And that surely the chances of them having coronavirus are now very, very small. And to Dr. Harries, we know that the testing isn't showing a true picture of the spread of the virus. How many people do you estimate have had or currently have coronavirus in the UK?
Well, thanks, Harriet. The answer to the first question is really clear, which is that this virus can spread in all sorts of different ways, both from directly respiratory and also through objects and through touching objects that others then touch. And the uncertainty over who has it, especially before they have symptoms, means that the only effective way of bending the curve down is to reduce that social contact. And that's why we came to the conclusions that we did, the difficult conclusions, that we have to have such extraordinary social distancing policies in place, and why we took the decision more than a week ago now to flip the basis of those rules from saying you can't do certain things to saying you must stay at home unless you're doing one of a small number of things, 4 things, which we've been absolutely crystal clear about those rules. And the evidence shows that a very high proportion of the public understand those rules, and a very high proportion of the public are following those rules, and we need everybody to be following those rules, and that's why we talk about them so much and the importance of following them. On the other question?
So I might just add to the Secretary of State's comments actually on that, because I think sometimes people get slightly confused. They're intermixing, if you like, the phrase family with household, and that's quite an important difference. So in infection control, public health terms, it is a household which is really important. So for example, if you're a group of students and you probably will be home with your family in one household now, but previously you might have had 5 students living in a flat under one roof, sharing cooking, bathrooms, all sorts of things. That, in infection control terms, is a household. So the important thing here is we know that households tend to have the same risk exposures, so they tend to have the same opportunity to become infected from one another, and it's one of the reasons why we have the stay-at-home family isolation policy. It's a household isolation policy. So if your family is with you, the likelihood if one of you had it, particularly after you've all worked your 14 days, then probably your risk low. It's possible that one of you may have had it and not noticed any symptoms particularly. But if your family lives in a different town, they are an entirely different household. And mixing those two is not what we want to do generally. So I think the difference between family and household, so it's stay with people that you live under the same roof with and keep doing that for as long as you can and safely. So that really just adds to that from an infection control perspective. And I can't answer your second question, and I'm not going to try, because that is exactly why we need to understand the immunity, the immune picture across the population. Obviously, some countries are a bit ahead of us, so somewhere like China, other countries, we learn where we can from reports that they do, and we're looking, but there is no country in the world currently which has good population-based serology testing for immunity to be able to say with confidence how many of the population have had the disease and which layers, which ages, which sexes, or which people with different characteristics. We just need to understand that in the future. So I won't hesitate to guess at this point.
Does that answer your question, Harriet, or at least explain why we're not able to answer it?
Yeah, just to clarify, so people who have only been going to the shops or only going out for exercise are still at risk of having coronavirus, having picked it up in those sorts of things you're saying, and therefore aren't safe to travel even by car to go and see family or friends.
That's right, and I have a particular interest in this, having had coronavirus and having come through it. Obviously, I've asked all these questions for myself, and as well as Secretary of State, and the rules are there for a reason. Even for those of us who've had it, where the science predicts it's likely that our immunity is higher and our ability to transmit the virus is lower, we are not yet confident enough in how much higher the immunity is and how much lower the likelihood of those of us who've had the disease transmitting it is, to be able to change the rules. So there is clarity on the social distancing rules for people, whether they've had coronavirus or not, and the rules are the same for everyone and will be until the science can give us confidence that we can say something different to those who have been through it. Final question, Paris from the Scotsman.
Thank you, Secretary of State. In the past few hours, we've learned that the Chief Medical Officer of Scotland, Dr. Catherine Calderwood, for the past 2 weekends has driven over 40 miles to a holiday home, taking with her on one occasion her entire family and on another occasion her husband. How damaging is that to your efforts to convince the public to stay home and save lives? If Dr. Calderwood worked for you, Mr. Hancock, would you ask her for her resignation? And can I ask Dr. Harries, is she still an effective spokesperson for the public information campaign? And do you have a second home that you visited since movement restrictions came into place?
Well, thanks very much, Paris. This is a matter for the Scottish Government, and they, I know, are addressing the questions that have been asked in Scotland. These rules are there for everyone. We couldn't be clearer that the social distancing rules are there for everyone to follow. I understand that the Scottish CMO has apologised, and as far as I see it, that is a matter for the Scottish Government to address. Thanks very much, everybody. That is it for today, and I hope that you, like me, will tune in to see the address from Her Majesty at 8 o'clock this evening. And thank you all very much indeed.